Yeah.
And we are live. So, a very good afternoon to all. This is Batul, the moderator for today's session from IGCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, ma'am needs no introduction, but yet it's our great pleasure and honor to introduce her. She's none other than the very renowned gynecologist, Dr. Shushma Pampanawar, ma'am. Ma'am is MBBS, DGO, OBG, DNB in Obstetrics and Gynecology, Diploma in Gynecological Endoscopy and Reproductive Medicine from Kiel University, Germany. She is the gynecologist, obstetrician, and infertility specialist at Ishwarya Fertility Center and Isha Hospital, Yelahanka, Bangalore. With ma'am's wonderful insights, we are going to talk about the topic for today, which is management of early and late miscarriage. So now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her for her precious talk to begin. Ma'am, over to you. Please proceed.
Yeah. Uh, Hi, everybody. I'll be speaking on management of early and late miscarriage. Actually, as a layman uses the term as abortion, abortion is actually a misnomer. We should actually call it as a miscarriage. So, what is actually a miscarriage mean? What does it mean? It is a loss of a pregnancy before 24 weeks of pregnancy, wherein World Health Organization takes it as less than 500 grams, or even since a 500 grams baby do not survive outside even if it is born, we take it according to the gestational age, we take it as 24 weeks, and earlier it was 22 weeks, and before that 20 weeks. So but since there is no standardization whether it has to be taken at 24 or 22 or 20 weeks, but according to WHO we still take it as less than 500 grams and less than 20 weeks of pregnancy. If there is the loss, whether in the form of a spontaneous by itself or we have induced it, we label it as miscarriage, also called as abortion. Next slide, please. So as I was already telling, whenever we come across a miscarriage, we usually go ahead with the management considering the following points. If she has bleeding, where is the site of pregnancy? First, we look at the site of pregnancy. We look whether it is a viable pregnancy or a non-viable pregnancy by doing a scan. This is how we usually start with the managing of a miscarriage. And once we label it as a miscarriage, we go and see whether it is a early miscarriage or a late miscarriage. Early miscarriage comes from the point that her urine pregnancy test is positive till 12 weeks of pregnancy, and from 12 weeks to 20 weeks we label them as late miscarriage. So once pregnancy test is positive and the patient has signs of any miscarriage, I'll tell you what are the signs, especially in the form of vaginal bleeding, pain abdomen, and sometimes dizziness and all that, wherein we take it as ectopic pregnancy, that is secondary. Once the especially the pain and bleeding, once a lady presents to us after her pregnancy test is positive, we manage them by first investigating by looking at the site of pregnancy, that is we do a transvaginal scan, we do a and we look for the fetal heart rate, in the sense whether it is a live baby or not a live baby. Sometimes if nothing is seen even by the scan but a pregnancy test is positive, we correlate by blood test, that is the beta hcg, wherein the blood values goes on increasing. Next slide. So, as I already told, the miscarriage can be in the form of a spontaneous. She herself has started to bleed, she herself has some pain and going for abortion. Or in the form of induced abortion, wherein the baby is not good and that is why we are doing a miscarriage, abortion. Or else it can be in the form of, once we label them as a spontaneous abortion, once we label them as a spontaneous abortion, we see whether it is the first time abortion or recurrent miscarriages, wherein we call it as recurrent miscarriages. So next, once it is either recurrent or the first time, we see what type of we see what type of miscarriage it is, whether in the form of threatened abortion, whether it is an inevitable abortion, whether it is an incomplete abortion, whether it is a complete abortion, whether it is a missed abortion or a septic abortion. Why am I classifying these? Because each one have the different methods of communication, different method of management. So this is about the first time miscarriage, or it can be even recurrent also. Once a lady comes to us with these features, that is bleeding and pain, we see what she fits into, what type of miscarriage, and based upon that we treat her. If it is an induced abortion, think the baby is not good, or some unmarried or some whatever it is, which we call it as illegal abortion. The most commonly it can go for septic if we leave that. So in that way, it can go for one. Just a minute. In that way it is called as illegal abortions, which is of course it has a lot of, India has a lot of strict guidelines for it. And if at all a legal abortion, whether it could be whether, which we call it as medical termination of pregnancy, either in the form of unwanted pregnancy, failure of a contraception, or by social causes, the lady is abnormal, physically or psychologically unstable, and she has become pregnant. All these are social causes, what we call. These are legal methods of miscarriage, which we call it as medical termination of pregnancy. Next slide. As I was already telling, the management depends upon what type of miscarriage does the lady fit into. So once I label the lady that the lady fits into threatened abortion, or in the form of missed abortion, we should know what does these terms mean. Only then we will be able to manage. Each one have their own way, each one have their own way of management. For example, threatened abortion, take it as a threatened abortion. Threatened abortion, next slide please. Threatened abortion, see, threatened abortion, usually there is a threat in the continuation of the pregnancy. Means the lady has bleeding, the baby is viable, and the cervix, the mouth of the uterus, the cervix is closed, but still there is a threat in the continuation of the pregnancy. Here, the management is just wait and watch, wait and watch. Give them complete bed rest, give them the support of pregnancy hormone, that is progesterone. Just wait and watch, do serial scans, and then if at all the body accepts it, it will continue with all this support, and it can go till 9 months of pregnancy, and she can even deliver. So this is one method of this is one form of miscarriage, and we manage this way. Coming to another form of miscarriage, that is inevitable abortion. Inevitable abortion means, or miscarriage means, inevitably the products of conception, that the abortus will come out. Here the mouth of the uterus, that is the cervix, is already opened up, and she has the bleeding, and it cannot be stopped. Here we just wait, and inevitably the abortus will come out. Here nothing else we can do, since because already the mouth of the uterus, that is the cervix, is opened up. Just wait, put some oxytocin, the products will expel themselves. Coming to incomplete abortion. Incomplete abortion is the mouth of the uterus, that is the cervix, is already opened up, and some of the products have already come out, and some of the products are remaining there itself in the uterus. Products of the conception remaining there in the itself, we cannot leave, because it is a focus of infection. For that, the management here is, we have to do a curettage, in the sense suction evacuation, which I will discuss it in further, how is the procedure done. Coming to other form of miscarriage, that is missed abortion. The word itself tells missed abortion, the heartbeat is missed. Here the lady can be asymptomatic, in the sense she may not have any symptoms, and it can be detected incidentally on the scan that the baby's heartbeat has been stopped. Or else she can come with bleeding also, mild spotting, brownish discharge, she can come, mild pain abdomen also she can come. And once we do a clinical examination, we see that the mouth of the uterus is already closed, and it is confirmed that the baby's heartbeat has been stopped. This has to be taken out. Here, there is no point in wait and watch method. For this, we need to treat her, give the medications, which we call it as medical methods of termination of pregnancy, or sometimes if it has already crossed 12 weeks, that is late miscarriage, we need to do a suction evacuation, that is surgical method. And coming sometimes we sometimes the other form of abortions, namely complete abortion, wherein the abortus has totally come out, she has passed a fleshy mass, she has passed the clots and all that, the total abortus has come out. Here, when we do a scan, we see the uterine cavity is empty, and the mouth of the uterus, that is the cervix, is already totally closed. For this, nothing can be done. Just counsel her that she had a complete miscarriage, and then ask her to wait for another 3 or 6 months of gap, and then plan for the next pregnancy depending upon her preferences. Next slide. So, as I was already telling, I will specifically concentrate on the management of early and late miscarriage, because this is a topic which has been given. As I was already telling, wait and watch. That is, one of the option is expected management, which has to be employed for threatened abortion, and medical management for missed abortion, early missed abortion, and sometimes incomplete abortion also. Complete abortion, again expected management, wait and watch because everything has come out. Sometimes surgical evacuation, that is incomplete abortion, wherein we remove the remaining retained products of conception. Next slide. So coming to, these are all about the management of the spontaneous abortions, wherein the lady herself presents with some of the symptoms of abortions, and depending upon what type it is, we manage. What about the induced abortions, wherein we call it as medical termination of the pregnancy? Induced abortions, as I already mentioned, it can be legal or illegal. Illegal because illegal abortions are very common in some parts of India. Government has come up with a MTP Act, and newer MTP Act also tells that it can be, government tells that MTP can be allowed till 24 weeks, and if the pregnancy has crossed 12 weeks, because termination of the pregnancy once it has crossed 12 weeks will be very difficult for the termination. The case has to be managed by two gynecologists, in the sense registered medical practitioners, two have to be involved, and if it is less than 12 weeks, one gynecologist can manage in the form of either medical or surgical. These are about the guidelines as to how to manage, because the government has to be involved in this, because to avoid the illegal abortions, wherein illegal abortions just inserting a stick into the uterus causing sepsis, and we have seen people even going for shock, septic shock, and sometimes excessive bleeding can go even for hemorrhagic shock also. Just in consideration of the mother's health and her health, we government has come up with this medical termination of the pregnancy act. Next slide. So that is what which I was already telling. Is abortion legal in India? Yes, it is legalized. And as I was already telling, less than 12 weeks, the pregnancy is there. Always take the consent form of the lady. Husband's consent is truly not needed. And one medical practitioner, one registered medical practitioner, a gynecologist has to be involved in this. And if it is a late abortion, late miscarriage, of course induced, two gynecologists has to be involved. The signature of the lady is needed. The signature of the two RMP, registered medical practitioners, are involved, and it is legal. Next. So, as I was already telling you, it depends even upon on what gestational age a lady has come to us, and how do we manage. As I was already telling you, less than 12 weeks, that comes to usually 6 to 8 weeks. We usually don't, that 90 days, what the government tells is, MTP Act tells, less than 90 days, go for medical methods, that is pills. MTP pills are available. And once we give the pills, they usually cause moderate to heavy bleed, and the products of conception come out. And once after 7 days we do a check scan to see whether any products are retained inside or not. This we call it as medical methods of MTP, or medical management of termination of pregnancy. And it usually it takes place at a home. We give the tablets to the home. Of course, it is not a over the counter drug. Many of the patients, they usually go to a pharmacy, and they ask for a prescription. But in India, it has been strict guidelines from the government that MTP tablets should not be given over the counter. Always a prescription is needed. And once we give these tablets, most of the times it is effective, wherein means all the abortus, usually 95 to 98%, the abortus will come out once we treat the patient. If it is less than, of course, it has to be less than 6 to 8 weeks. What about the pregnancies who are between 9 to 12 weeks? Here, preferably to go with surgical management, that is suction evacuation or manual vacuum aspiration, wherein manual vacuum aspiration is a small tube is inserted, which is again connected to a vacuum, or a syringe form which can act as a vacuum. Either it is connected to the electric board, wherein which call it as electric vacuum aspiration or suction vacuum aspiration, or if it is just connected to a syringe and we just extract those, we call it as manual vacuum aspiration. It doesn't need any electricity. It is just like a big syringe we put inside the tube and we take out the contents just by vacuum suction evacuation. So up to, if it is, that's what, if it has crossed 8 weeks, that comes to 9 to 12 weeks, go ahead with manual, that is surgical evacuation, either in the form of manual or by electric vacuum aspiration. Then here usually the once we do this is like a curettage, this is like a cleaning sort of thing, and it usually takes hardly 5 to 10 minutes, and it may need sometimes short general anesthesia, and it has to be done in a OPD settings where at least minimal anesthesia techniques of can be given. Coming to previous slide please. Coming to those who have already crossed 12 weeks, which we call it as late abortions, here gentle curettage can be done. Sometimes we even give medicines for them. The abortus will come out with the tablets, the MTP medicines come out with the tablets. Sometimes there are chances that they may be retained. That time we again do a surgical evacuation. That is medical methods followed by a surgical evacuation. Or else we can even go ahead with the direct surgical evacuation. And since it is done under sometimes ultrasound guidance, and we know that the products have totally come out, it is usually 100% effective. Means there are no chances that the products will be left behind. Whereas in medical methods, what happens, once we give the tablets, some of the products may come out and some may be retained, which we call it as incomplete. That time we again need to do a surgical management. That is again cleaning it. That is check curettage is what we call it. Next slide. Coming to the medical management, which I was already telling, pills, which we call it as medical termination of pregnancy, MTP pills. So what is a MTP pill? What does it contain truly? It contains misoprostol, that is prostaglandin E1. Government of India, that is our FOXY guidelines, has given at what gestational age, what is the dosage of the medicines. Coming to one of the this thing is early pregnancy. If you want to do a medical management, think I was already telling you less than 8 weeks or 90 days or whatever it is. Think early pregnancy has come to me 6 weeks and it is a missed abortion. Heartbeat has already stopped and I want to do a termination of the pregnancy because there is no point in waiting and watching. I'll give her medical management, that is in the form of the tablet, that is MTP pills. What tablet? That is misoprostol, mifepristone. There is a tablet called as mifepristone followed by misoprostol, which is available as a MTP kit. The tablet mifepristone is given, which helps for the initial placenta to separate, and following 36 to 48 hours, 800 micrograms of tablet misoprostol is inserted vaginally. This misoprostol helps to contract the uterus and the products of conception will be expelled. So this is how the misoprostol, that is prostaglandin E1 acts. And at what gestational age, what is the dosage has been mentioned. This you can even get it from the guidelines, this thing also. Usually, for it is available as 200, 400, and 800 micrograms of tablet, and we usually start with the 200 micrograms. Sometimes we even give it orally also. I told you 800 is inserted vaginally, and sometimes if the lady is not able to insert it vaginally, we give it 200 micrograms every fourth hourly, fourth hourly, fourth hourly, 4 doses, with which the uterus contracts and she expels the products of conception inside her home only. On the it can be given at her home only, wherein she will report us back to us after 7 days for a check scan, and we tell them and we do a scan and see whether the products, few of them are retained or not, or it has totally come out. So this is how the tablet misoprostol, and these are the dosages which we give, which is recommended by Foxy. Next. Next slide, please. So coming to surgical evacuation, how is it surgical evacuation done? Surgical evacuation, as I already told, whether in the form of electric form, wherein it needs an electricity for the suction, or in the form of a syringe, just a manual vacuum aspiration. If it is surgical evacuation in the form of electricity, we give a short general anesthesia. We hold the anterior lip of the cervix. We dilate the cervix, and we put a ovum forceps wherein the products can be grasped and it can be taken out. This is called a surgical evacuation. Next slide, please. So coming to all this time, I was just speaking about early and late miscarriages. Sometimes a lady can present with recurrent second trimester abortions. That is, after 12 to 24 weeks, a lady presents with every time she has the miscarriage exactly at 16 weeks, 17 weeks, 18 weeks. That we call it a second trimester losses. The previous slide, the most common cause, previous slide please. The most common cause for second trimester miscarriage or late miscarriage is usually the cervical incompetence, wherein the cervix is incompetent. It cannot hold the products of conception. You can see in the first picture that the mouth, the cervix is totally closed. The layers of the uterus, the cervix is totally closed. Whereas in the second picture, you can see the black color thing, that is the amniotic sac, has prolapsed outside. The mouth of the cervix is, that is the uterus, that is the cervix, has opened up. This we call it a cervical incompetence. So how do we manage cervical incompetence? Logic. It tells that the cervix has to be tightened up, which we call it as encerclage. Next slide, please. So, what is encerclage? What is encerclage? Is the cervix which is opened up. We put a purse string suture. We just go around the cervix and tighten it so that it will hold the contents, and the lady can go till 9 months of pregnancy. This procedure is called as McDonald's cervical encerclage. Next slide. So as I was already again telling, one of a when do we call it a this recurrent miscarriage? One of a cause is this cervical incompetence. When do we usually call them as a recurrent miscarriages? 3 to 4 consecutive abortions, we call it as recurrent miscarriage. Of course, it can be first trimester loss or a second trimester loss. Second trimester recurrent pregnancy losses, the most common cause is cervical incompetence. Recurrent miscarriage in the first trimester are usually because of the fetal abnormalities. I'll discuss this further. Next slide. How do you manage a recurrent abortion? As I was already telling, recurrent abortions in the first trimester can be a chromosomal, that is the fetal abnormalities. The baby's chromosomes itself are not good. So in that way, here we do a management. We manage by checking for the karyotyping of both the mothers, both the parents, that is the mother and the father. We do the karyotyping, and yes, if at all the karyotyping is abnormal, we treat it by IVF, or the karyotyping comes to be normal, we do a in vitro fertilization with PGD, wherein genetically selected good embryos are selected from. Next slide, please. Previous slide, please. And that embryos we put up inside the uterus, which we call it as pre-genetic diagnosis. Next, if at all, if it is due to the age related factor, we plan for donor egg. or we plan for some medications followed by to increase the quality of the egg, and then we plan for self IVF. Recurrent abortions can also be because of uterine anomalies. That is, the uterus anomalies. Sometimes the uterus will be two uterine cavities, and the baby will not be, the uterus will not be able to hold the contents. That time we do a surgeries, we do metroplasty, or some extra tissue is growing, which we call it as a septum. We do correct that uterine anomaly, and then we plan it. This is how we manage recurrent abortions. Sometimes even endocrine causes such as thyroid problem, prolactin problem has to be treated accordingly. If even PCODs can also cause recurrent abortions, we try to correct the PCOD by diet or lifestyle modifications, and this is how we manage a recurrent case of abortion if it is due to PCOS. Sometimes even recurrent infections, which we call it as torch infection. Of course, it has been, we know that torch infections, that is toxoplasma, herpes, and all, usually don't cause recurrent, but they cause sporadic abortions. We give vaccinations, and this is how antibiotics, vaccinations, and we try to manage the pregnancy. Next slide. So this is how, this is just a broad this thing overview of how we manage a case of either it is a late or a miscarriage. The main funda here is just see what is the cause for her miscarriage. Depending on the cause for her miscarriage, we take a proper decision as to how the lady should be treated. Any questions, I can ready to take it.
Thank you so much, ma'am. Thank you for your overwhelming talk that you have shared on our platform and for making our viewers understand about the topic in such a better manner. We have received a few questions from our participants. So with all your due permission, I would like to put across those questions to you. So the first question is related to the diagnosing of non-viable early pregnancy on ultrasound. So what is the criteria for diagnosing a non-viable early pregnancy on ultrasound, ma'am?
So usually once the pregnancy test comes as positive, once a pregnancy test comes as positive, we go back and see her last menstrual period. In the sense, we see for the gestational age, in the sense how many weeks of pregnancy she is. So once we all this we do it, we do a scan. Usually the scan findings to tell it as a pregnancy is the events how it occurs is it initially starts is seen as a gestation sac, which we see it by 5 weeks of pregnancy. Once the gestation sac is seen, inside the gestation sac we see a small ring which we call it as a yolk sac. Inside the yolk sac, by this yolk sac is seen by 5 weeks, 4 days, or whatever it is, and followed by the yolk sac, a small ring-like structure is seen, which we call it as double ring sign or a finger ring sign. We see a fetal pole that again 5 weeks, 5 days, and by 6 weeks we expect to see the heartbeat. Please remember, 6 weeks we see the heartbeat. So a lady has come to me, and she her LMP was almost 1.5 month back, and I have calculated her gestational age that comes to 6 weeks. I have done a scan expecting that I should see a heartbeat. Correct. So once I see the heartbeat, I am not able to see the heartbeat. What could be the cause? So probably it can be a late pregnancy, slow growing pregnancy. We repeat a scan after 10 days just to see for the heartbeat, just to see for the heartbeat. And of course, if we see it later, think I've seen today, for today she's 6 weeks, and after I see her after 10 days or 7 days, by that time she should be 7 weeks or 8 weeks, but still the heartbeat has not come. We call it as a non-viable pregnancy, that we call it as missed abortion. Or sometimes unhealthy pregnancy can be seen as a big gestation sac which is empty. Actually she is 7 weeks, but I'm not able to see the fetal pole, I'm not able to see the yolk sac. We again label it as a miscarriage, which we call it as blighted ovum or anembryonic gestation. This is how we diagnose as a non-viable pregnancy. Next
Thank
slide.
you so much, ma'am. Thank you. Thank you for answering that question. Moving ahead with the another question, and the next question is, And the next question is related to the HCG levels. So, how should HCG levels be interpreted in the context of early pregnancy loss?
So it is nothing like we have to see it in the early pregnancy loss. Beta HCG is a one hormone which will tell the lady is pregnant or not. Sometimes the beta HCG values to tell the lady is pregnant or not is more than 50 values. We take it as pregnancy. But of course, just the value more than 50 doesn't mean that it is a healthy pregnancy. Values, we look for doubling. This is what we look for: doubling of the beta hcg, wherein we check for the beta hcg after 48 hours. We expect to see the levels to be raised after 48 hours. It has to be doubled. In that way, we label it as a healthy pregnancy. Sometimes the values are 1000 beta hcg, it is a confirmed pregnancy. But after 48 hours, if the levels are falling, that is the value which was 1000 has come to 300, it means it is a unhealthy pregnancy. So in early pregnancy, sometimes, because a scan will not show us so early, 4 weeks we will not be able to see nothing in the scan. So for the early pregnancy loss, as such early pregnancy loss, we need not just check it by beta hcg levels. Beta hcg is just to tell that where the pregnancy is, whether it is an unhealthy pregnancy or a healthy pregnancy, just to tell that, and how the pregnancy is going on. To monitor the levels, it will tell us.
Thank you so much, ma'am. Thank you for answering that question. With this, we would like to move ahead with the other question, and the other question is related to the last question, which is of how should labor induction be managed in case of late miscarriage?
Late miscarriages, that is what, think for example 19 weeks pregnancy, not called as labor induction, we call it as again MTP. First thing. So how do we do? We directly cannot go for a surgical methods, because already the bones, the fetus has already formed. It is almost around 400 500 grams. What we do is do a medical management. Give them the tablets, misoprostol, either 200 or 400, depending upon what time pregnant she is. Because first time pregnant, 19 weeks, we can directly give 400 micrograms, or else previous 2 times cesarean, now we are aborting it. Either it can be because of fetal anomaly or induced abortion for some other cause. We can just give it 200. Give them the oral medication, make the uterus to contract, and once do a clinical examination. See how the uterus is contracting by doing a per abdominal examination, do a vaginal examination, see for cervical thinning, that we call it as ripening, and then we can go ahead with the oxytocin, that is putting oxytocin, so that it will expel the products of conception. Sometimes even if we do all this, the products might still be remaining. That time we go ahead with the surgical management, that is incomplete abortion.
Thank you so much, ma'am. Thank you for answering that question and all the other questions for our viewers and for making them understand about this topic in such a better manner. I would like to thank all our viewers for their ardent participation, and I would also like to apologize them for starting a bit late. We were having some technical issues because of which we started late. But still, thank you everyone for staying tuned with us throughout the session and putting across such interesting questions to us, and for listening to the whole webinar. Thank you so much. And thank you, ma'am, for your valuable time. With this, we would like to conclude the session here for today. Until next time. Thank you.
Thank you.